Hey everybody, it's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers podcast. We have another guest today. Her name is Dr. Ellie Campbell. She is a DO and an integrative physician practicing functional medicine. And so, Ellie, welcome to the Thyroid Answers podcast. We're going to talk about blood pressure. Some people may be like, why are we talking about blood pressure? But it's a huge issue. You typically see blood pressure, cardiovascular issues in people with hypo or hyperthyroidism. So I think it's a good topic. I don't think we've had anybody on the podcast to talk about it. So I'll have lots of questions. I'm sure you've got lots of answers. So we'll get right into it. But welcome to the show.
Thank you so much. It's my honor and pleasure to be with you today. Yeah, I'm really excited about blood pressure. It seems pretty mundane. It seems like, oh, geez, every time I go to the doctor, they always check my blood pressure. They tell me it's fine or they tell me it's not, and then I need to do something about it. But in fact, 50% of Americans have hypertension, and only a quarter of Americans have their blood pressure under good control. And it's a major contributing risk factor to the number one killer in our country, which is cardiovascular disease. So we are missing a grand opportunity. And I don't want your thyroid patients focusing on thyroid and neglecting their cardiovascular health, walking straight into the emergency room with a heart attack or stroke because they were so focused on their thyroid, they forgot to look at their blood pressure, right?
Yeah.
So,
well, and I think it's interesting because a lot of those patients that have thyroid related conditions due to poor cellular health, they may wind up definitely on too much meds, wrong types of supplements, and that can actually exacerbate some of their cardiovascular issues. And then there's a whole world of people that we'll also probably want to talk about, which is the people who have orthostatic hypotension. They don't regulate their blood pressure well and have even maybe some low blood pressure. So we can get into that. But before we get too far, let's give the listeners a little bit of background about who you are and what you do currently and why and what we're really kind of the passion for what we're talking about today.
Yeah. So for 32 years, I have been a board certified family physician. So I'm a family doctor, cradle to the grave, see kids to grandmas and everybody in between. And for the first 13 years of my career, I practiced in a community health center. So we saw lots of folks who were disadvantaged, come from socioeconomic troubled places in our community. And I got to see a lot of disease, all sorts of disease, from gout to cancer to heart attacks and strokes. And I practiced the best evidence-based medicine that was out there. I was the physician champion for our diabetes collaborative, and we had stellar data to show how good we were taking care of these patients. And I became really good at writing prescriptions because the average diabetic's on 3.2 hypertensive medications, plus aspirin, plus cholesterol medicine, plus something to control their blood sugar. It was a nightmare. And in 13 years, I really never saw anybody get better. I saw them stabilize, but I didn't see people resolve chronic illness. And I felt frustrated by that. So I started learning integrative and functional medicine, and a whole new world opened up to me about root cause resolution, about how to get to those antecedents and triggers and mediators, and what is driving this person's metabolism and cellular health that we're missing, or what do they got in them that we need to get rid of to make their bodies work better. And once I started doing that, miracles happened. And people started getting better. And we started tearing up prescriptions and getting them off their medications. And they got their health vibrancy back. And that made my life joyful. So for 18 years, I've been solo practice. 3 weeks ago, I hired a new junior doctor. So she's coming with me one day a week. She's the mother of newborn twins. So can't say I'm solo anymore, but I was solo for 18 years. And about go ahead.
No, go ahead. Finish your statement, then I'll jump in.
So I was going to say that about 9 years ago, a patient of mine, one of my very favorite patients, her name's Dee. Her daughter was my patient. Her daughter came to see me at age 42 because she was unable to get pregnant. And she already had a younger son, but she was told that her husband and her DNA was not compatible and they shouldn't be parents. And she's like, but I already got one kid, so I'm not sure. So we did all of our functional medicine things, and Cheryl got pregnant and had another baby boy. And after that amazing experience, her mother came to see me. She said, well, you're so good with pregnancy hormones. Maybe you can help me. I'm a bit older than my daughter, but got this much younger boyfriend and I could use a little bit of hormone help. So Dee had hypertension, which we controlled with medicine, hyperlipidemia, which we controlled. We started her on some diet and lifestyle changes, and she got started on some hormone replacement, and things were going great, I thought, until one day Cheryl called me hysterical that mom had not shown up for work that day. And when she went over to the house, she found her mother collapsed on the floor next to her computer. She'd had a dense hemiparetic stroke and she was paralyzed on one side. And I felt like somebody punched me in the gut because this was my patient. I was responsible for managing her blood pressure and her cholesterol, which we were managing according to the best evidence-based guidelines. But I missed something. And somehow she had this horrible stroke. So it was too long of a time for her to qualify for these beautiful clot-busting drugs that can sometimes be used to erase a stroke if you get to the hospital fast enough. But Dee didn't qualify for those. So she went across the street to the stroke rehab hospital. And something tragic happened over there. It's called hemorrhagic transformation. And it happens when the weakened blood vessels that were weakened in the stroke burst. And she developed a brain hemorrhage and Dee passed away. And I just felt so somehow I was supposed to be her guardian angel and the system failed us because she died of the number one killer in her country, cardiovascular disease, even though she was being treated for cardiovascular disease. So what did I miss? And I started on a journey to figure it out. And out of that journey came the blood pressure blueprint and all of the tips and tricks that I wrote in my book. It comes out on Amazon next week. And I'm thrilled. That's November 14 of 2023. And I'm thrilled to be able to share some of my tips and tricks and what I learned about Dee that has saved every patient since then, because since in the last 6.5 years, we have had 0 heart attacks or strokes in any of my patients. And because we've been able to get that root cause healing done throughout the entire COVID pandemic, we lost 0 patients in my practice. So it's all about treating the cell. It's all about treating the patient in a holistic way to get rid of the barriers and give them what their cells need. And once we figure that out, magical things happen.
So one of the things that you talked about, I think is pretty important, is that you were treating a patient, managing a patient's condition. That's allopathic medicine. That's what you were taught. That's what the schooling is. That's what the guidelines are. So you're doing the traditional stuff. So it's not like what you were doing was wrong by those standards, and right. And so that's kind of
straight and narrow, following the guidelines.
So that is standard of care. So we were following the standard of care. The problem is it's really not the standard for healthcare. It's the standard for disease management. And that's a different job. So you actually have a different job today than you did before. And I think that's one of the things we have to consider is that people hear a podcast like I have, they'll read a book like maybe you have, and then they're going to go to an allopathic physician who's practicing allopathic medicine and want what I say or do, or what you say or do, and then they're frustrated by what they get back, right? And so I think the important thing is, and I want you to talk to that, is why people really need to understand, because I came from the medical world, came to this world, and I was angry with that medical world because I was like, how are you not seeing what's going on here? But then you soften as you get a little older and a little wiser. You go, okay, these are primarily good people doing exactly what they're taught, trying to help people. But what they're doing isn't doing what you or I are doing. We're trying to address the root issues to try and restore health. Or really what the job that you were doing was the managing the disease, not trying to correct but manage. Is that correct?
100% correct. And, there are 2 different spheres. And in my practice, we overlap them. But I'm a very rare bird. There's not that many practices that do both disease management and wellness treatment, right? Prevention. There's very few. So I happen to love doing it this way. I love having my prescription pad and being able to write prescriptions when I need to, but also the magic, where my joy and my satisfaction comes in, is when we help patients achieve their health goals without medication, with therapeutic lifestyle changes, with nutrient depletion, with stress management, with adequate sleep, with identifying. And this is, I'm going to go ahead and let the cat out of the bag. The number one, what happened to Dee, the reason why she had a stroke, was that 2 weeks prior to her major event, she developed a toothache. That abscessed tooth leaked lipopolysaccharide. It's a protein that comes from the gram-negative bacteria that live in that abscess, that got into her bloodstream and caused a rupture of the artery in her head that caused her stroke. I didn't know Dee had a toothache. She didn't tell me. I didn't learn about that until 2 years later, when I'd been to a conference and I learned a methodology to help reduce the risk of cardiovascular disease to near zero. And I called Cheryl up, the daughter, and I said, Cheryl, I think I figured it out. I guess I might know what happened to your mother. Did she by any chance have a dental problem? She goes, well, she was scheduled to have a tooth pulled 2 days after her stroke, but she never made it to the dentist appointment. And my mind was blown, because here it was in my learning paradigm in my classroom, and I was able to apply it to an actual case. Unfortunately, it was too late for Dee. But fast forward now, I've learned that the number one hidden risk factor for the number one killer in our country is oral health. And if people are missing out on this oral health connection, they are not going to get optimal risk reduction, and they're going to be risking heart attack, stroke, and even thyroid disease. I mean, there's a lot of evidence that the wisdom teeth and the teeth right in front of it energetically connect to the thyroid. And when there is a lot of drain on the immune system because the patient has a root canal tooth or they're fighting a chronic periodontal infection, that the immune system's being drained and the thyroid is becoming inflamed from all that junk that's in those teeth that are located very close. And so keeping your teeth under better control can help your blood pressure, reduce your risk of stroke, heart attack, kidney disease, thyroid disease, breast disease, cancer, and more.
Yeah, all the systems interrelate, right? And so for the listener, because you have some gum disease doesn't mean you're going to have a stroke tomorrow. But
it does not.
This person probably already had some predisposing factors that contributed to, but that was probably, yeah. So this was probably
on the camel's back.
Yeah. And so what I typically talk about, maybe you talk about this in your practice, a lot of times we're looking for the thing that does everything, but I think that's naive of us in most situations. What's really driving the problems is what I call the load, which is my poor diet, my poor lifestyle, my disrupted sleep patterns, my poor breathing. And these are cumulative factors that grow and grow over time. And so our stress load builds. We're not doing much to reduce that stress load. And at some point, we exceed the capacity that throws us into this kind of danger, high inflammatory state, like something like that then triggers a more significant event. So,
and that was COVID, right? COVID was that inflammatory straw that broke the camel's back for so many people during our pandemic. It simply was the pandemic on top of the pandemic. We already have this chronic illness pandemic where people were doing all those things you just talked about. They're not eating, they're not sleeping, they're not stress reducing. And then we have this massive inflammatory virus come into our world. Many people just could not handle it. So outside of a pandemic, the thing that I see that's that trigger is the oral health. And it happens over and over and over in our practice now. Because I do, we can look at lagging indicators or we can look at leading indicators. And most of my patients would rather do blood work that is predictive of a problem. So I can look at these inflammation markers, lipopolysaccharide, LPPLA2. I can look at myeloperoxidase. I can look at oxidized LDL, 8-OHDG, F2 isoprostane, ADMA. These are blood markers that tell me that the patient's in a high state of inflammation. Well, now I have a grand opportunity to lower their inflammation. I call it emptying their bucket. You call it reducing their load. And by doing so, we can reduce their risk. They can handle the next thing that comes by without that tragedy, that health tragedy that lands them in the emergency room or the hospital or worse. So when I do those leading indicator blood markers, it's really helpful. And then we look at how much oxidative stress, how much inflammation, and then other things too, like sleep.
Let me slow you down a little bit, because I want to make sure that we kind of walk through a process here and make sure that we take the listeners on a little bit of a journey. So we're going to talk about blood pressure, right?
Sure.
And so let's talk about blood pressure. And for some people, let's start with the basics. There's a lot of physicians and practitioners that listen to the podcast, but there's a lot of lay people. So let's talk about the real basics of blood pressure. What are we looking at when we're talking about blood pressure? What's the upper number? What's the lower number? And what is it really measuring?
Yeah. So when we look at the history of blood pressure, it's actually kind of crazy. You would think there'd be one number that everybody agrees on, but it turns out that's not the case, that the World Health Organization has a slightly different definition than the American Heart Association, than the CDC. They're slightly different. Everybody agrees that a normal blood pressure is 119/79 or less. Everybody agrees that's normal. Now, 120/80 is considered elevated blood pressure by the CDC. 120/80.
And so when did that start? Because in the past, the 120/80 was considered the norm. So when did that change?
2017. Okay. And then 130/80 is now considered stage 1 hypertension by the American Heart Association, American Medical Association, CDC. World Health Organization pushes it a little bit. We say, so those three groups, 130/80 is high blood pressure, stage 1. 140/90 is stage 2 hypertension. And 180/110 with symptoms is a hypertensive emergency. Get your butt to the hospital.
Okay. So what's the top? Tell everybody what the top number means, what the bottom number means.
Yeah. So these are measures of pressure. Technically, if you're a geek, technically they're measures of height. Believe it or not, in the old days, we used to use a mercury column attached to a wall, and they would measure how many millimeters of mercury that column of mercury went up with each heartbeat, and then how much it came back down again. So it's technically a measure of height. But what we use it now with our non-mercury automated blood pressure cuffs, the first number is how much pressure it takes for your heart to squeeze all the blood out during your systolic heartbeat. And then the second number is how much back pressure is left when the heart's in relaxation. So it's how much pressure and how much is left when you relax. It should never go to zero. If it goes to zero, you have no circulation. So nobody wants their blood pressure to be zero. But a good number, 120/80. That's what we're going to aim for.
Okay. And then but you're saying the new number is the 119/79, right?
119/79 technically.
And technically, how much difference does that 1 point of each of those numbers make?
It's a very gradual scale. So little by little by little, each single point adds a tiny bit of risk. For organ damage from that high pressure state.
Okay. And so when we look at blood pressure, we're saying 119/79. Mm-hmm. Is that a static number? Does that meaning, could that number be the same when I'm laying down, when I'm sitting, when I'm standing? Could it be the same?
Yeah, no, it's not a static number. It's very dynamic. It should change. If you squat and then stand up again, you're going to need more blood to your brain. You're going to need a little higher pressure head to get that number up, but it should come right back down. And for that reason, they have standardized the way in which we check blood pressure. They don't want you checking your blood pressure when you're deadlifting 100 pounds. They don't want you checking your blood pressure when you're chilling, lying down for 4 hours. There's a very specific way to check blood pressure. And that is sitting down, bottom to the bottom, back to the back, feet on the floor, empty bladder, proper blood pressure cuff, arm hanging at your side, and one other thing. Oh, no clothing. The cuff is not on clothing. And so when you do those steps, those 7 steps, then that's a standardized approach to checking blood pressure.
So is there a challenge or a problem with doing that, especially in today's world where a lot of people may have a problem regulating blood pressure appropriately? And should we just have everybody sit down and say, this is the only way we're going to check it? Or would it be better for people to have their blood pressure checked in multiple positions to make sure that they're actually regulating it appropriately, especially the elderly population who are often on multiple blood pressure medications, to manufacture a number, then not allow it to regulate appropriately?
Yeah, that's a really great question. And you're a really big thinker, right? So we're trying to regulate, we're trying to make public health decisions with public health data. What you're talking about is on an individual case with an individual person. And the same is true like young people with concussions, right? They often will lose that ability to regulate their blood pressure. And these are very serious medical conditions. That's not the guideline that we're looking at when we say 50% of all Americans have out of control blood pressure and only 25% are controlled. So I think that you're right. In the big picture, in the big scheme of things, that sort of data collection is going to prove to be invaluable over time. But right now, we have a huge population who just seated static regulated blood pressure the way we do. They're not in target. And nobody's talked to them about any way to manage their blood pressure that could make a difference in their long-term outcomes. So I love your ideas.
In your shift from allopathic medicine to functional medicine, have you started doing that in your practice, or are you still staying with the standard seated?
No, we call those orthostatic hypertension readings, right? So the patient starts lying down and sits with their legs dangling, which you're not supposed to measure your blood pressure with your feet dangling when you're looking at static blood pressure medicines by convention. And then we stand up. And so we check our blood pressure and our heart rate, those 3 different ways, to see how well the body is compensating with those position changes. Right. And there can be many reasons why that's dysfunctional and many reasons why that's dangerous to a patient.
Yeah, especially in the elderly population, who the primary cause of death is primarily falls, right? And so now you have a person who's got blood pressure issues. They're on blood pressure medications, which is affecting their circulation. They're not getting proper blood flow to their extremities. They're probably developing some level of neuropathy. And now they get up in the middle of the night. They can't see well. Their balance isn't great. They can't feel their feet. And they have orthostatic hypotension due to maybe the medications not allowing them to regulate appropriately. Right. And within seconds, they fall down, they hit their head.
Right. And another issue too is that, historically, we took all the control as medical doctors, and we just wanted patients to come get their blood pressure checked and then see me in a month and get your blood pressure checked again. Right. So I have two readings over 30 days, and I'm supposed to make a therapeutic decision based on that. Yeah. And, I would never, for a diabetic, make a therapeutic decision based on a single finger stick reading in my office today and 4 weeks from today. That's ridiculous. Right. And so home blood pressure monitoring is now becoming much more accepted. Unfortunately, it's rarely covered by insurers. So people have to go out of their own pocket. And here we have that same dichotomy, right? What is conventional medicine and disease management, and what is functional medicine and prevention? And so managing your blood pressure at home is more in the second category, should be in the first, but it's not yet. So ambulatory blood pressure monitoring and frequent home blood pressure monitoring are becoming more accepted. and should be absolutely utilized, especially in those higher risk populations or people who have symptoms that might be related to their blood pressure. We absolutely need to be getting a bunch of data. Send me some readings. Send me 10 or 20 readings over the course of a couple of weeks. Let's look at it. Let's look at it when you're stressed. Let's look at it when you're happy. Let's look at it when you're calm. Let's look at it after coffee. Let's look at it in the morning. Let's look at it in the night after a meal and get some data. And then we get a better global picture of how the patient might need to be managed. And
it's one of the
medications are dangerous things. And if we can ever get a patient off their medication and managed with therapeutic lifestyle changes, nutritional supplements, herbs, teas, anything else that has a safer safety profile, I'm all for that.
So I for my clients who are on blood pressure medications, one of the things I may have them do is, especially as we're making those diet and lifestyle changes and addressing some of the things that are driving inflammation in their system, because it's one of the things, say, this blood pressure medication may have been appropriate when it was prescribed,
right?
But as we're doing things that are reducing inflammation, that blood pressure medication may now become part of the problem. And when you start to have certain symptoms, it's probably going to be that we're going to have that blood pressure changed. And if you walk into your primary care's office saying, hey, this functional medicine practitioner I'm working with said I need to change my blood pressure medication, the doctor's going to be like, based on what? And you're probably going to walk in with white coat syndrome, terrified to ask them, your blood pressure is going to be back up again. And they're going to be like, I'm not making a change. So I ask my clients to monitor their blood pressure on a regular basis so they can take a month's worth of data or more into their clinician to say, hey, look, here's what I'm doing. And I've been monitoring my blood pressure all the way along, and this is what the readings have been. And so it sounds like you think that's a good strategy, but that's
a great strategy.
So the question becomes, and maybe you have a better insight, there's so many devices out there for people to monitor blood pressure. Since this is your baby in your wheelhouse, what's like the best home blood pressure tool to use to get more reliable data? Have you seen that?
There's not the American Heart Association has a program called the Million Hearts program, and they publish a list of all those that are acceptable. In general, I don't like the finger or the wrist cuffs. I don't think they're reliable enough. I do like an arm cuff. It has to be properly sized. There's guidelines as to how large your arm is and what size cuff you need. And the problem is that even in most doctors' offices, they have the wrong cuff and it's giving the wrong reading. I, in that over 60 crowd here. So, we get this little bit of stuff here, right? So I need a large blood pressure cuff, but it's not long enough to get all the way around my arm. If we go up to an extra large cuff, it's too thick. It covers between my elbow and my shoulder. I'm only 5 feet tall, so I don't have a big arm, and an extra large cuff is too big, but a large is too small. And so Welch Allyn understands this. They've come up with a large, extra long blood pressure cuff, and that's the size that I need. So for most people, I would say this is probably the most common size that we use in our office, large, extra long. And if you get the right size cuff, you're going to get better readings. So the home blood pressure cuff monitor that I like the best is Omron, O-M-R-O-N. It's available everywhere. You can get it off Amazon and get it at Walmart. It's not very expensive, and it seems to give really reliable readings. Now, we're starting to get into the world of AI, and we're starting to get in the world of wearables. And we're hoping, I think when the Oura Ring first came out, blood pressure was one of their promises, that it would be able to measure your blood pressure without a cuff. Same for the Apple Watch. I don't think we're there yet. We're not ready for prime time. So do not, even if it gives you numbers, trust but verify with an actual blood pressure reading.
Yeah, I would agree with that. I think all this stuff is great, but it's not all is accurate as we think it is, but it gives us ideas, it gives us trends. But I agree, there's probably a good arm cuff is probably the best. So I'm glad you brought that up. So let's dig into the next step, which is if we had to give somebody a general idea of what causes blood pressure, let's talk about blood pressure to rise first. What's the biggest drivers increasing blood pressure?
Well, I think if we go back to the alphabet, we have our ABCs, right? I think it's airway and breathing. These are probably the two leading causes of hypertension in my practice that I overlooked for many years. And first, the airway that I'm talking about is sleep apnea. So many people are mouth breathers. When they breathe through their mouth at night and they're snoring, they're changing their oral pH. They're making an acid mouth that makes an unfavorable environment for the friendly bacteria that live in our mouth to be there. They like to be in a little more alkaline saliva. They don't like to be in this acid environment. Mouth breathing makes an acid mouth. And when you get this shift in bacteria, we have a miracle mouth molecule called nitric oxide. It's made a lot in our sinuses. It's made in epithelial cells. It's made in blood vessel cells. But the enzyme that converts into nitric oxide has a name called nitric oxide synthase, and it's made by bacteria on our tongue. And if we don't have a friendly mouth bacteria, we miss that enzyme, we can't make nitric oxide. Nitric oxide is one of our most powerful vasodilators. It opens the blood vessels. It opens the blood vessels on our coronaries. It opens the blood vessels in our brain. It opens the blood vessels in our genitals. And in fact, the research on nitric oxide and eventually developed into the pill, the little blue pill called Viagra, because it dilates those blood vessels. Well, you make your own Viagra if you have good mouth bacteria. So we want to make sure that you're not mouth breathing. Noses are for breathing, mouths are for eating. If at night your mouth is open and you are snoring, you must get tested for sleep apnea. And it's easy to do.
Let's talk about that for a second, because I think what happens many times is we say, oh, the reason that you have this is because you have sleep apnea. But sleep apnea isn't the reason you have the issue. Sleep apnea is we call disordered breathing, right? But what's ultimately often driving the diversion from nasal breathing to oral breathing? What do you see as the big challenge there?
Yeah, there's many. I think that first of all, we think about fascia, we think about tongue ties, we think about historically children ate gnarly foods. They ate root vegetables. They chewed on bones, and we give our kids baby food. So these kids end up with these very poorly developed facial muscles. Their jaws are smaller historically in the 2000s than they were in the 1900s, than they were in the 1700s, than they were in the 200s. So we're getting these smaller faces. And then we get crooked teeth. So we go to the orthodontist and they pull 4 teeth so that they can make room for our smile. And we wear braces and they put us in headgear and we get this face, our foreface, pulled backwards to almost guarantee no room for our tongues. So people in my generation, the 50 to 70-year-olds, we see a lot of this orthodonture-related sleep apnea from small oral airways that were caused by the treatments that, in good health, in good guidance, following the best evidence based of the time, they were pulling our teeth and making beautiful smiles with small airways. So that's one thing. As these kids are not chewing, not using their muscles of mastication, they end up with weak oropharyngeal muscles. And then when they sleep at night, everything relaxes and they tend to get sleep apnea. So We can treat sleep apnea, not with a CPAP machine. We treat sleep apnea with an assessment of their fascia, with oral myofunctional therapy, which is like physical therapy for the mouth, lip, and tongue. And we treat it with an assessment of their nasal airway, because you get nasal disuse atrophy. The more you breathe through your mouth, the less your nose works. So we have to retrain that process. So as we do those things, we can make the airway better and the sleep apnea gets better.
So that's great, because that's what I wanted to get into. Because the easy answer would be somebody's like, well, I did get checked for sleep apnea. I now have a CPAP device. I've already dealt with that. But that CPAP device doesn't address the root issue. It's just putting a fighter pilot mask on, and now you're forcing oxygen into the tissue. But again, depending on how it's the type of mask you have, it may be contributing to the problem, because it may be contributing to more oral breathing and less nasal breathing. Where do you see the role? Because when the greatest problem we really have in this country is a chronic low-grade inflammatory state due to diet and lifestyle. And so where do you see the role of inflammation, especially at night, playing a role in impacting nasal breathing? Because we do go through a nasal cycle at night. And if there's already a level of inflammation, and a lot of people have experienced this, they lay down at night or evening time, they start to get more stuffy, more congested. Then they lay down, and almost to a patient, I will talk about nasal breathing versus oral breathing, nose taping, mouth taping to make sure you're nasal breathing. And everybody swears that they don't breathe through their mouth, they don't snore. Somebody would obviously tell them if they did that, and they would know if they did. And no, they don't. I just spoke at a dental and airway conference early in, I think it was September, and talked about the connection between thyroid physiology and oral health. So I'm all on board with what you're saying. But do you see that the role of this low-grade chronic inflammation not only impacting blood pressure, but also creating more nasal congestion at night, and then helping to divert somebody to, hey, they're asleep, they don't know what's going on, right? So, hey, this thing's not working, especially if there's, as you go through the nasal cycle on one side, if there's a blockage on one side or a deviated septum, then it's really bad. Do you see that as a potential another reason for driving the problem?
Absolutely, I do. And I think that the role of food sensitivities can't be forgotten here, because I think that's one of the drivers for many people of their low-grade inflammation, is especially dairy and gluten seem to really cause a lot of that nasal stuffiness, and acid reflux too, right? I mean, so we get this thing called laryngopharyngeal reflux, and you may not feel it. It may not feel like acid burning, but you're getting acid trickling up your back of your throat to your vocal cords, and even up into the back of your throat, and even into your sinuses. And that can be a trigger of nasal congestion and oral breathing as well. So, it's all connected. And yes, inflammation is probably the driver, the primary driver of almost all of these things. Between oxidative stress and inflammation, if we can get rid of those things, we can probably get rid of 80% of chronic disease in the United States. And the nice thing about, once we start identifying these triggers of inflammation, the trickle-down benefits are so many. I've seen people get their sleep apnea treated and lose 30 pounds without trying, because they're not choking anymore at night. Their heart's not being strangled. Their cortisol's not through the ceiling. Cortisol is our body's stress hormone. And if we're stressed all night, we're making a lot of cortisol. What happens to people who take steroids? They blimp out. Well, They're not taking them, they're making them. But if we can calm all that down and get deep restorative sleep, and I do like the apps for sleep. I don't like the apps for blood pressure, but I do like a watch or an Oura ring to help you figure out, are you getting into deep sleep cycles? Are you getting into good heart rate variability? Are you getting enough hours of sleep? Because I think that's another place that drives chronic inflammation, is we don't give ourselves the gift of enough time in bed. to get enough restorative sleep. And
Yeah.
when we do, blood pressures come down.
Yeah. And I agree with those things. And for the listener, I probably said this before. I know I just said this on another podcast interview I just came off of, but when you breathe in appropriately, you're blowing off a lot of carbon dioxide. And there's multiple things that can drop the blood and circulating carbon dioxide levels. It's acidosis, but it's ordered breathing for sure.
Yes.
And if you're breathing off too much carbon dioxide, you can have a 99% oxygen saturation if you check it and you say this is great, but the oxygen on the red blood cell doesn't do the work. It's getting the oxygen off the red blood cell and to the cells and tissues that then allows those cells to run via oxygen, which is really what we need, because that's how we do the best job converting food energy to cellular energy. But if you're mouth breathing through the night, you're going to reduce the amount of oxygen that's getting to the tissues, because the red blood cells don't want to give it up. And then what happens is you get reduced oxygen to cell. That triggers stuff inside a cell called hypoxia inducible factors. And that causes an adaptive down regulation of your mitochondria and your thyroid function. And this is where Dr. Ellie was talking about, hey, we see people lose weight. One of the things that happens when you're chronically mouth breathing is you deactivate your thyroid hormone at the tissue level, slowing down metabolism, forcing you to have reduced metabolism. So just changing your breathing at night from oral breathing to nasal breathing can be a simple thing that can improve your thyroid conversion and improve your metabolism. So it's so important. How difficult is it to get people to the reality that some of the tools, like do you advise like mouth taping and breathing exercises as part of the strategy?
Yeah. So I think here we have that dichotomy again of the conventional medicine people. Their knee jerk is obese people need sleep tests, needs CPAP, right? And that's like their one trick pony. And here on the integrative medicine side, we're trying to look at the root cause. What causes that sleep apnea and how can we fix it? And it's much harder. And I need a team of expert specialists to help my patients, an ENT team, a dental team, oral myofunctional therapy team. But I'm also able to get many more people to do a sleep test when I say, guess what? Not every patient with sleep apnea needs CPAP. In fact, it's kind of my treatment of last resort. Meanwhile, and even the people who invented the CPAP, it was intended for a short-term treatment, short-term, get your oxygen levels up, let's get you out of the danger zone. And then we're going to work on all the therapeutic lifestyle changes that we need to do to get you back in shape so that you're nasal breathing again and not needing CPAP.
Right. And I agree. I mean, if you need it, you need it, right? But it shouldn't be just, okay, we're good, right? But to be fair, not everybody wants to put in the work to address the real lifestyle factors and the things that are driving it. So yeah, we need that stuff for the people that don't want to do it. But for the two people that do want to do the work, the nice thing is about like with a practice like yours, you can say, okay, here's what's going on. Here's a strategy. You can do this and we'll keep you alive, or we can do this temporarily to get you kind of a little bit better. But if we do the stuff over here that caused this, you may never need this thing. You may not need this thing long term. What would you like to do? And then you can give them both options, right?
Yeah. The sad thing is that, there's also one other treatment for sleep apnea that it has the highest cure rate of anything, and it's surgery. It's called MMA surgery, maxillomandibular advancement surgery. It's a big deal. They cut your face in half. They cut your jaw in half. They pull your entire front face forward 7, 8, 12 millimeters, put bone grafts and pins and screws in there and pull your whole tongue forward. And it's curative about 90% of the time, and insurance covers it. Because that's the problem, is we have this drastic treatment covered by insurance. We have CPAP covered by insurance. And then we have all these root cause resolution things that aren't covered by insurance.
Right.
Right? We're paying out of pocket to do dental expansion therapy. We're paying out of pocket to do myofunctional therapy. We're paying out of pocket to do lip taping and nasal splinting. Why can't I run to the pharmacy to get a prescription for lip tape and pay $2 on my copayment? Right? You don't. You have to pay cash for it. But yes, I do. I love my lip tape. If I was stranded on a desert island, I would want my lip tape because it makes my sleep so much better. I work with a myofunctional therapist. I'm admittedly a terrible patient. I do not do my exercises the way that I should. So I lip tape. And I have really good nasal airway. So I don't need nasal splints. I don't need breathe right nasal strips, but many of my patients do. My husband, who has a terrible nose and really needs nasal surgery, but is refusing to go, says,
I agree with him because
taping is a recipe for suffocation. And
yeah,
I'm like,
that's not true.
it is not a recipe for suffocation.
Right.
But if you're not a nasal breather and you have nasal disuse atrophy, you can't expect to spend 8 hours with your lip tape the first night.
Yeah.
You're going to have to watch TV for 30 minutes with your mouth tape on and get used to it. It might take a little bit.
Yeah, and that's the same recommendation I make. And I feel for your husband because I've had multiple broken noses, deviated septum. I'm afraid to go get the surgery. I'm like, oh, I don't want to get it done. But I do, especially if I do anything that triggers a little bit more inflammatory state, a little bit of
you
alcohol.
Feel it.
Oh yeah, you can't breathe at night. I'm definitely opening my mouth. I've been blessed to not have had any cavities, but I think it's such a really important and simple thing somebody can do to just start to improving their health and well-being. I had a brand new client, just talked to her a couple of days ago, yesterday, Monday, and she's talking about her sleep and disrupted sleep, and this is the top of the thing. And I mentioned, hey, gave her a little questionnaire. We got her to fill it out. I'm like, hey, why don't you try mouth taping? That's ridiculous. Blah, blah, blah. And she's like, I do not breathe through my mouth. And I'm like, how do you know you're asleep? And so I got a message from her today. She said, okay, I did the mouth tape. My deep sleep went up. I think she had an extra hour of deep sleep. And she's like, and I feel better. So she's like, okay, maybe you were right. But so many people don't know. And then this leads to problems with more inflammation, more hypoxia, because if the person's hypoxic all night, what is that going to do to blood pressure?
Absolutely. It's going to drive it up. And we're going to get more arrhythmias, atrial fibrillation, all these low oxygen conditions. Not
necessarily always low oxygen in the blood, right?
Right.
So I think that's the important piece. I think what you're also saying, I mean, could we have low oxygen in the blood? Yes. But really what we're talking about is at tissue, right?
At the tissue level and inside the cell, where the mitochondria are. We got to get that oxygen across the cell membrane. And if we're too acidic, we're not going to do that. So, I think I had a patient who I started on lip taping, and he called me back the very next day. He goes, this effing tape is an effing miracle. Mm-hmm. He goes, why did nobody ever tell me about this before? He was like, I slept for 8 hours. I haven't slept for 8 hours in 15 years. It was a miracle. And it's continued to be a miracle for him. He continues to do it. Now, there's all kinds of mouth tapes on the market. And some of them are really fancy and they look like lips and they're pretty and all that. You can horizontally tape or you can vertically tape. Mm-hmm. Me personally, what I found works best for me is I use a 2-inch roll of tape and I cut about a 3/4 inch strip off of it. I fold the corners back, 4 corners, and then I tape it from the middle of my girl mustache to the middle of my chin, and I pull it down vertically. And I do that for a couple of reasons. Number one, it does leave the corners of my mouth open. So if I cough or sneeze, I can get air out and I don't feel restricted at all. I'm a very copious saliva maker, and I will gurgle in my own saliva. but if I can drool a little bit when I need to, I have a hole on the side of my mouth. My lip tape doesn't prevent that. And this hardly happens now. It used to happen all the time. I would have a glass of water at the bedside table because my mouth would be dry. So at the beginning, I would put a straw in the glass of water and I could stick the corner in the corner of my mouth and drink without having to take tape off. I don't need to do that anymore. I don't get dry mouth in the middle of the night anymore. I don't need a sip of water because I don't dry my mouth out because I sleep with the lip tape and I'm solid and it's not necessary anymore. So if you have a glass of water at your bedside table, you should probably get a sleep test.
Yeah. So glass of water, dry mouth when you wake up. If you have cavities, frequent cavities, gum disease,
Dragon breath.
These are all the indications that there's something going on with your disordered breathing, and regardless of what you think, you need to be probably evaluated. So I want to make sure that we're talking a lot, but we're not getting that maybe always to the root of the stuff. This happens a lot. That's why we go a little bit longer on the podcast, because I like the longer conversations. But you wrote a book, right? And so give us some insight into what the book's about and what some of the key aspects of the book are and why a person might want to pick this book up and read it.
Yeah. Well, I wrote the book. I have to really tell you a secret. It's really kind of a Trojan horse. What I think people need to know about, but I put on the title Blood Pressure Blueprint because that's what people want to know about. 50% of America has elevated blood pressure. It's been in the top 10 Google searches over the last 10 years before COVID. People Google blood pressure. They want to know what they can do about their blood pressure. Well, you and I both know that if we treat oxidative stress, inflammation, breathing, and oral health, they're going to get better. And so that's what the book's about. It's about all of the therapeutic lifestyle changes, about all the different ways that you can approach your health and your blood pressure will get better. But people don't care about that. They don't care about their oral health. They don't Google nutrient deficiency symptoms. They don't Google, right? So they Google blood pressure. So that's where I'll meet them where they are and teach them what I think they really need to know to help their blood pressure.
Yeah,
also,
I don't. Go ahead.
I was going to say also, because many people who will pick up this book already have hypertension and they're looking for a way to maybe get off of their blood pressure medication. There's a bunch of tips and tricks in there. First of all, many of the blood pressure medications on the market are drug muggers. They steal our micronutrients. We require a lot of manganese and zinc and magnesium to metabolize these drugs, and deficiencies of those minerals will raise our blood pressure. So the longer we take these medications, if we're not working with a functional medicine practitioner, the more we're getting nutrient depleted, the more nutrient deficiencies we have, the more we have joint pain and thyroid trouble and gut problems and general fatigue and brain fog and slower memory. Well, they're nutrient deficient. The blood pressure medicines did this to you. So I talk about you should get your zinc level checked. You should get your magnesium level checked. You should get your omega-3 level checked, coenzyme Q10 level. And so there's a bunch in the book about how to identify and treat these deficiencies. Furthermore, most people are familiar with the adage, you need to be low on salt, give up salt. Salt's bad for you. Wrong. Salt is good for you.
Right.
But you got to pick the right salt. Just like we shouldn't be eating white flour and white sugar, we shouldn't be using white salt. We need salt full of minerals. And so it's colored, it's gray or it's pink, it's Celtic, it's Himalayan. So we want to use a better salt. And many people are salt sensitive only because they're magnesium deficient. So we get the magnesium built back up. Now all of a sudden they can tolerate the salt. And there are some people who are indeed sodium sensitive. I'm not going to say that's not true because there is a subpopulation of people who are salt sensitive. But you need to do the test. You need to be on a very low salt diet for a couple of weeks. get me 20 or 30 blood pressure readings, then go on a high salt diet for a couple of weeks and get me 20 or 30 blood pressure readings. Let's see what the differences are. And but make sure your magnesium and zinc replete before you try this experiment, and then see how you do. And if you're truly salt sensitive, we'll cut back the salt in your diet, but it's not the majority of people.
So I think that salt story is an interesting story, and I agree with you that it's not the demon everybody makes it out to be, but I think it might be worth having a quick discussion as to why sodium got so demonized as the problem.
Yeah, well, I think it sort of goes back to when we started processed food. When we stopped cooking, people started eating processed food. And now we look at the grocery store. Where is the majority of the food in the store? Is it on the perimeter where it's fresh and you have to cook it? Or is it in cans and boxes and in the freezer section, right? So these processed foods, in order to get their palatability up, they're often frankenfoods. They're genetically modified. They're cooked in seed oils, and they're very, very heavily laden with salt. And so we started seeing our blood pressures go up as a population, and they blamed salt when really salt was just a component of a crap diet. So I think that you can eat a lot of fresh foods, vegetables and fruits in particular, a rainbow, try to get 7 colors of vegetables or fruit every day in your diet. If you eat those highly nutrient-dense phytochemical foods, you'll buffer a lot of the salt. You can put salt on top, but if it's not laden inside the food to begin with, you're going to be able to taste the salt, but you're not going to be overdosed on salt.
And so is this salt, the big issue with the salt and excessive amounts of salt, maybe the quality of the salt was that salt, water follows salt, high levels of salt in the system, more fluid in the system, and that really was contributing to part of the problem?
Yes, so people end up with some edema. So you can see that swelling hitting when you press the skin, you see a little dimple because they're retaining salt and water. But sometimes it's not visible in the ankles. Sometimes that edema fluid is in the bowel wall. And so the patients just look puffy in the middle. And we see those beer bellies every day, everywhere. Some of that's edema fluid. And it's from eating the wrong salt and not enough of the real food. And then it can drive blood pressure elevations because you're retaining salt and water. You're filling the blood vessel with extra fluid. That's putting a stretch on the blood vessel, and that's what raises the pressure.
So when we're talking about blood pressure as this kind of guide, and somebody say, okay, I want to lower blood pressure, and really we're talking about how do I improve health? We talked about oral breathing as, not doing oral breathing, more nasal breathing, kind of retraining that. But if we had to talk about the other kind of, let's say, top 3 or 4 things that you think really drive health issues and higher blood pressure, what are those top 3 or 4 things that you would suggest?
I would say there's 2 foods that people are eating that they need to get the heck out of their diet and never return. One is fructose, high fructose corn syrup in particular. But if it's in a fruit, that's an exception, right? Fructose sugar inside a whole piece of fruit with the skin and the fiber and the phytonutrients, that's fine. But once you take it out of the fruit and it's an ingredient on a label, fructose is horrible. It drives insulin resistance, it drives diabetes, it drives obesity, it drives hypertension. So number 1 is get out fructose. Number 2 is seed oils. So these are oils made from sunflower, safflower, canola. Those seed oils are highly inflammatory and they drive the inflammation that raises the blood pressure. So that's 1, 2 foods. A second thing I would say is oral health. If you have pink in the sink when you brush or floss, this is a 911 dental emergency to me, in part because of what happened to my patient D. I know that that inflammation was the final straw on the camel's back. And since I don't know what the underlying patient health looks like, if you're Joe Schmo off the street and you have pink in the sink, you probably have a very full bucket of inflammation. And now you're adding to that this lipopolysaccharide, these mouth bacteria that can get in your bloodstream and trigger events. We want to get your oral health under control. So I would say breathing, 2 foods, and oral health. Those would be my top 3.
Okay. And for the listeners, because you've probably heard us talking about this before, lipopolysaccharides are the outer coating of these gram-negative bacteria, and they have the ability to not just trigger inflammatory responses, but it can trigger these LPSs, these what we call PAMPs, pathogen-associated molecular peptides, can be the things that activate the immune, the inflammatory system. But keep in mind that the PAMPs can also bind to what we call pattern recognition receptors on the thyroid gland itself, initiating thyroiditis. So really important to keep in mind that bacteria and oral bacteria should be in the oral cavity, not getting into the bloodstream. Gut bacteria should be in the GI tract, not getting into the bloodstream. But when we start to create breakdown to these barriers, now we have these things coming into the system that shouldn't be there. And there's a lot of people that have chronic oral infections, oral dysbiosis, and that contributes or is a huge driver for their chronic immune inflammatory conditions. So the stuff that we're talking about here isn't specific to high blood pressure. It's not specific to thyroid. This is just general health stuff. I wanted to ask one more question on that topic, because we did spend a bunch of time on oral health and the implications that it can have on somebody's health. But I wonder what your opinion is. We have, you and I grew up in this era where mouthwash was this really important thing to do. I've got an opinion on some of these things. What's your opinion on people using mouthwashes on a consistent and regular basis?
Right. So I'm glad you asked, because before you asked that question, I was going to stop you and talk about correcting oral dysbiosis is not a DIY project. You do not want to get napalm in your mouth and kill all the bacteria, because we need those friendly commensals. We need the help. Your mouth should have bacteria in it. It should have lots and lots of friendly, healthy guys. They're what keeps our gums healthy. It keeps it's a barrier, because we put all those food in our mouth, right? So we use those bacteria that are in there to help keep the bad things that we might be eating from the dirt that we put in our mouth, keep them at bay. So we need those friendly bacteria. Do not use mouthwash. If you use off-the-shelf mouthwash, Listerine, for example, that's napalm in your mouth. It is going to kill the friendly bacteria. It's going to kill the nitric oxide synthase forming bacteria, and it's going to raise your blood pressure on average 6/4 millimeters of mercury using mouthwash daily. So we do not want to use mouthwash daily. If you feel like you need a little breath freshener, a toothbrush is a really good way to do that. And getting the mouth bacteria into good balance by chewing a good probiotic for your mouth is another good way to get your mouth in better health. Xylitol is a polyol. It comes from birch bark. It's naturally occurring. Humans also make xylitol. It's the final ingredient in the final common pathway of vitamin C metabolism. So we make xylitol, but if you use xylitol in your mouth, it's very refreshing. It improves saliva flow. It acts like a prebiotic for the friendly bacteria. And mothers who use xylitol 4 to 6 times a day during their second trimester and third trimester of pregnancy through the first year of child's life will have children with close to 0 cavities for 5 years of age. So mothers using xylitol pass the benefit on to their newborn babies and give their babies a much healthier, friendlier flora. and they don't need mouthwash, and they don't get cavities.
Yeah. So I think that's because we grew up in that era where that was,
Yes,
you got your
minty,
bottle of
fresh, and
scope, right?
clean.
Yeah. And so somebody might be listening to this and going, I thought that was healthy for me, right? And this kind of starts to fall into the category of eggs are bad for you because they have cholesterol, right? That a high carb diet is better than a high fat diet, right? That all these kind of these things that we grew up on that we're now learning, 10, 20, 30
Oops,
years later were the
oops, we
things
were
that,
wrong.
yeah. And they created these issues. And so, um, you know, just because somebody says something or you see an advertisement on TV doesn't mean that it's correct. It's just maybe based on somebody's current level of bias or ignorance or knowledge base. But it behooves us to start asking more questions about the advice we're getting. Like, does that make sense to use an antiseptic in my mouth every day? But we never knew there was oral bacteria, right? That there
Right,
should be some. Nobody ever taught you that before. And now we realize, oh my gosh, there are some bacteria there. There should be there. There could be
right.
bad stuff there too, but we need to take care of our oral cavity. So I do want to respect the time. I do want to say what I want you to do is gonna give three like general overall tips that somebody could use. If somebody's got high blood pressure, what are the three top tips you would give them? And then I want you to just plug the book and let people know where they can hear more about you and your book.
Awesome. Thanks, Doc. So I would say 3 things for blood pressure. Number 1, make sure you're breathing well at night and through the day. Number 2, eat a plant-based diet. I don't mean you can't eat meat. I mean mostly plants, 7 different colors every single day. No fructose, no seed oils. And see your dentist and have a really good oral health checkup, because no cardiovascular prevention program is complete without a dentist and a hygienist on the team. I believe that heart attacks are optional, strokes are stoppable, and dialysis is not your destiny. You can do this if you're willing to do the tests, do the work, and read my book, The Blood Pressure Blueprint, now available on Amazon in ebook and paperback as of November 14th, 2023. I'm Dr. Ellie Campbell, and it's been my honor to be with you today.
All right. Well, thank you so much. As Dr. Ellie said, it's the book about blood pressure has the pull to pull you in, and there's probably more valuable information. So whether you have blood pressure issues or you don't have blood pressure issues, it still might be a great book to take a look at. So Dr. Ellie, thank you so much for coming on the Thyroid Answers podcast. At some point, maybe we'll have to have you back and finish our conversation, because I feel like we only just started tickling the surface of what we could have talked about. So I do appreciate you coming on. Thanks so much for coming on the podcast, and maybe look forward to talking to you again. Okay.
Your health, my friend.